Emerson, it's just you and me.
Man, our compadre is has bailed on us.
He is uh he is MIA, so to
Yep,
speak.
definitely miss
Well,
him.
you know what? I think we can get through this thing and somehow come out the other side with a wonderful episode. We've got two guests with us today. We've got Dr. Greg Jackson and Frank Hoyland, both associated with the MUSC healthcare system down in Charleston, South Carolina. So we're a little jealous of where they live.
Right.
And they're gonna talk to us today about a pilot program and um, uh, a some research that they've done at their facility related to patients who have a significant cardiac disease and undiagnosed sleep apnea.
I think it's exciting that we're actually talking to a cardiologist. I mean, you and I have been circling this story for over a decade, and it's usually a pulmonary person or sleep person. And we always say, man, if we could get cardiology on board.
Yep,
And now we've got a guy who's doing it, and I'm so excited to get to hear what they both have to say. But I think just the fact that they were able to get that kind of engagement is extraordinary.
I agree. Hey, well, let's jump in and get to the episode, and I'll start the episode with lights out.
Now, a word from our sponsor, Medbridge Healthcare. Medbridge Healthcare is a leading provider of sleep lab management services and home sleep apnea testing. Medbridge partners with hospitals, healthcare systems, and medical academic institutions to offer comprehensive, fully integrated services for sleep disorders.
Welcome everyone to the Sleep Tech Talk Sleep Podcast. Not the typical and usual voice that you're accustomed to. Jerry George was not able to make it to today's recording, so you've got to live with Emerson and I. But we are so glad that you joined us today. We have an exciting show. We've got Dr. Greg Jackson, who is an advanced heart failure and transplant cardiologist, but who also has been working in the world of sleep medicine. And we've also got with us today Frank Hoyland, who's a respiratory therapist and registered sleep tech at MUSC. We appreciate these guys joining us today. And guys, we're going to jump right in because we've got a lot to cover. And I'll turn it over to you, Dr. Jackson, if you will sort of tell us a little bit about yourself and how you got interested in sleep medicine, and then we'll pass it off to Frank.
Absolutely. Thanks, Robert, and thanks, Emerson, for having us today. So like Robert said, I'm an advanced heart failure and transplant cardiologist at MUSC in Charleston, South Carolina. And really got interested in this when I joined faculty. One of our former faculty in the sleep medicine division, Dr. Robert Verona, approached us in the cardiology section and said, we're kind of working in silos. How can we collaborate together and help our cardiology patients with sleep disorder breathing and the needs of the sleep medicine division? So we started having meetings a few years ago, and things evolved, and we've set up a really nice collaboration, including Frank Hoyland, Dr. Verona, and Dr. Jackie Angles a few years ago, really developing a pretty robust program with inpatient and outpatient screening and trying to help our cardiology patients with all of their comorbidities.
So I am Frank Hoyland, registered respiratory therapist, registered sleep tech, respiratory care practitioner, also bachelor's business administration, healthcare management. And I've been in the field for probably close to 30 years. Starting out obviously low on the totem pole and working my way in. And I went backwards. I was in sleep first, then went to respiratory because I seen the need for the comorbid conditions and the treatment of sleep patients that is actually getting kind of scary at some points. In some facilities, it's pretty tricky. Had a few codes, different things like that. So I'm like, okay, I need to learn just a little bit more. So I went backwards from sleep into respiratory and then kind of flourished that in. Once I got to MUSC, met Dr. Jackson, our later medical director, Bob Verena, he has left us since, and so has Dr. Jackie Angles. just remaining as me and Dr. Jackson holding up the fort right now. But yeah, we really seen the need to try to interject sleep into the world of the hospital. It just so happened that Dr. Jackson and Bob Verona started like a pilot program, basically looking for, is there a relevance? You know, what's the prevalence of this? What's the statistic? And I think that kind of meandered around for about 6 to 8 months. And I think they had, what'd you have, Greg, like 3 or 4 patients? Somewhere in that vicinity, I think.
Right.
Yeah.
Yeah. So I think the first probably 6 months of our pilot program, we only had a handful of patients until we really got sort of a inpatient sort of sleep navigator, sleep medicine coordinator sort of a role on the inpatient units, and then things really took off.
Well, Dr.
Yeah,
Jackson, since we've sort of ventured into the inpatient screening program, do you want to talk a little bit about the overall program and what you were able to fully get launched, and what I know that you guys have done some research based on your the findings from your pilot program. Do you want to walk us through that and tell us a little bit about the program? Because I think our audience is going to be extremely interested to hear sort of the prevalence and the outcomes of the research that you've done.
Yeah, absolutely. Yeah, I think, we started this as sort of a pilot program. We worked through hospital administration to be able to do inpatient sleep studies. Myself and Dr. Verona, a number of years ago, finally got approval to say, yes, you can start doing these inpatient sleep studies with sort of the home sleep test platform. And that's kind of where Frank came in, helping to start getting people screened with sleep questionnaires. If they tested positive, we got them set up for a formal sleep study before they left the hospital. And really what we needed to focus on is, these are either heart failure patients or patients coming in with recurrent atrial fibrillation, some sort of cardiac comorbidity, which is highly associated with sleep disordered breathing. And I think, in our world, in my world of heart failure, roughly, up to 80+% of people who are hospitalized with acute decompensated heart failure may have some variety of sleep disordered breathing, either obstructive sleep apnea or central sleep apnea, or mixed. And that's really where we were, sort of found these staggering numbers and said we could really make an impact. So Frank started rounding with, at the time, we had 3 different inpatient cardiology teams. He would screen patients through a computer program, which he helped kind of customize through something that the hospital has a computer program with, to identify these patients, do sleep questionnaires on them, and if they tested positive, really get them set up for a home sleep study. We screened probably 1,000 patients or so in the span of about a year. And really, like Frank alluded to, it was really slow to get off the ground. The first 6 months or so, we were relying on the cardiology teams to notify us of patients that they think might have sleep apnea. And as you can imagine, when people are hospitalized with cardiac issues, the focus is on the cardiac issues. The focus is not on the other comorbidities, the sleep disordered breathing, the things that are, we're just looking at the tip of the iceberg with the recurrent atrial fibrillation, the heart failure hospitalizations, but under the surface is a lot of sleep apnea. And so very few patients were getting referred to us. And as soon as we had sort of boots on the ground, in this case, Frank started rounding with the teams, integrating into the inpatient units, working with the nurses, identifying the patients. Things really took off. And that was around the onset of COVID. So we had a little bit of inertia, if you will, to do a little bit more kind of telemedicine and testing outside of the formal sleep lab, where numbers and staff and quarantine issues were starting to take place. And over the span of a year, we screened about 1,000 patients. About 200 of those had a formal diagnosis of obstructive sleep apnea, and we got about 110 of those patients started on therapy. And when we went back and looked at the numbers, we found a significant reduction in hospitalizations, either any cardiovascular hospitalization, whether it be heart failure, recurrent AFib, MIs, arrhythmias. And we also found a significant reduction in mortality. And when we looked at specifically adherence, which I think is becoming more and more of a focus, is, adherence to therapy, hours of therapies per night, and percentage of nights of the week. We found that people who were more adherent over 4 hours a night for greater than 70% of the nights had a statistically significant reduction in mortality. So I think we found a lot of interesting things from this program. For better or worse, a lot of that was pushed forward with the COVID pandemic. And so I think what we're trying to do now is evolve and develop more of an inpatient program. I'll let Frank comment on, his work, really needing boots on the ground to get this program running and evolve sort of a sleep navigator position, or, an inpatient sleep specialist kind of a position.
Yeah, with the numbers, we do have some research, some abstracts, and some published information now. Some in LVAD, some in just regular heart failure population. But it's okay if I give those numbers, correct, Dr. Jackson? I'm looking at them right now, and it's pretty significant. Yep. For the adherent population. 3 out of 28 patients had more than one cardiovascular readmission. 1 out of 28 had 1 readmission or less, and 0 deaths on the patients that we actually were able to test, screen test, put on therapy, and stayed adherent to therapy. Now, when you go backwards to the other side of the non-adherent population, we had 27 out of 81 patients that had more than 1 cardiovascular readmission. So that's from 3 to 27. In the less than 1 cardiovascular readmission, we had 15 out of 81, and we had 10 out of 81 deaths. And that is in the non-adherent, not on therapy, I don't need it, it's not my problem, that population. I would like to say, first and foremost, when I first started, it's a nutshell game, like Emerson, like Emerson had said, with, you got to keep in mind, I'm a respiratory therapist, sleep tech. I'm in this realm of attendings and fellows and residents, and I'm trying to not bust the bubble, so to speak, to educate and make them see something that they're not used to looking at it from my side of the fence. But as Dr. Jackson said, they treat heart failure first. But what sleep apnea to me is it's a big boat anchor. So they're doing all this treating, and they're not going to get anywhere, because just as a code, when you run into a room, you do not just do CPR. I mean, you do CPR, but you do not just do resuscitation. You know what I'm saying? You got to do airflow. They go hand in hand, and it's the same thing when they're treating the patient with medications at a metabolic rate, all those types of things. There's just a lot of little kind of intricate things that we tweaked, and out of that spawned this whole. It was about, we were just talking about this, me and Dr. Jackson, about a 6 to 9 month period. The attendings were literally coming to me and giving me paperwork with patients' names on them, that because I'm trying to round on 50 patients, 3 different teams, and I wasn't able to get to them all. And if I didn't get to one, the attendings literally would come to me and go, hey, here's the name and the room number of this patient. Can you please go see what we need to do? If we need to do anything, if we do, put the orders in. And because I'm an RCP, I can actually put the order in. And then, of course, the attending has to sign off on it and everything.
Frank, what you guys are talking about is incredible, because it's a multimodality approach to care, and I think we're seeing that more and more across sleep and medicine, as the hospitals are recognizing to the point.
Yeah.
So when you both of you were looking at this program and beginning to launch it, what do you feel like was the biggest turning point for your program to take it to that next level? Because 1,000 patients is extraordinary. What was that kind of turning point for the program that put it on that course of success that you finally enjoyed?
So I mean, from my angle being on rounds every day and every week a different attending. So they rotate because we're a teaching facility. So it was actually scary at first, but then I got thinking more about it. I said, this is a great opportunity because each week I get a different brain, a different person to program, a different person to teach something, without teaching. Like I literally would just do it so cashmere and
So
easy
I'm going to
that
pause
they,
you. So you didn't make the mistake of, if I build it, they will come. You were selling. You were proactively educating, marketing, selling, doing what you could to help the physicians in the system understand what you were doing.
yeah, and I did that through focusing on the patient and the patient population. And I used LabWorks, and there's some little tricks that I have that I look at things differently. And I kind of got caught a couple times teaching residents and fellows, and the attending was over my shoulder going, "Oh, really? What is that?" And and then they start paying attention and are like, "Well, you can't really go by that." And I'm like, "Yeah, as long as your creatinine's good, because I was looking at like the liquid CO2 and a basic metabolic panel or a comprehensive metabolic panel, lab work, just basic. And we now know, and I mean, I'm sure Robert knows, and anything above 27 is obesity hyperventilation syndrome. That's documentable. So I was using that as kind of like a tool to quickly look at the patient. And then I also developed a Tableau system that kind of gives me information, and it's usually about 88% right. So I was using that tool. But the turning point was when it went from 4 patients to like 300. And they were like, surely all these people don't have sleep apnea. And it ended up it went from like to 80 something percent. And then it was like, oh my God, and you could see literally the attending like, we can't turn left of this. Like, and then when I was actually trying to create, I think we need a different position other than sleep navigator, because I was actually screening, basically diagnosing, not in the terms for the attending, and putting them on treatment. And in the process, we decreased hospital readmissions by 2% and kind of increased the hospital length of stay by almost half a day in the patients, that we were treating. So when you, as an attending, when you see that happen in conjunction with an EF of 15, and we had a patient, he had an EF of 17, kidney failure as well, put him on GDMT medications. I put him on BiPAP. That kid now has an EF of 50 something, but because he was in heart failure so long and not treated for sleep apnea, and obviously your kidneys are the biggest functioning problem with heart failure, the next thing that comes, and he ended up having kidney transplant, but he didn't have a heart transplant. So he went from EF of 15 to an EF of 50 something because I got inside his head and told him, look, bro, you got to wear this. All this medication you're taking is not going to metabolize if you're not breathing. And you're going to be in sympathetic activation even after you wake up the next day for 4 or 5 hours. So you're at a huge deficit. This is the metabolic thing you have to pay attention to at 36 years old. And that kid still, he has my personal cell phone number. That kid still texts me to this day. Hey, bro, just checking on you, making sure you're still helping people. Just random craziness. He's texting me every once in a while, but
That's really cool.
yeah, the need is there. The need is
Yeah.
there, and that was the turning point. Is when the doctor's seen like the tidal wave was coming. You either
Sure.
swim or you drown. Like
Yeah.
there's no.
And I think
No, and I think that's where it really makes a difference. Dr. Jackson, where you were about to say something, when you think about this from the standpoint of physicians, we, as you pointed out, there's, so many of your patients are going to have some type of sleep disorder breathing. For you, with this program and the study, what was your turning point? Where did you probably knew this was true, but to see it live, under your guidance, where was your turning point with it, your epiphany that this is much bigger than you thought it was?
Yeah, I think like Frank alluded to, we had trouble trying to find patients and identify patients. And once we started doing didactic lectures, with the residents doing either morning or noontime lectures on their cardiology rotations, having a presence on rounds and having people talk about it and bring it to the forefront, not just focusing on their cardiac issues. Yes, we were doing that, but then saying, might this person have sleep apnea? And in such a short period of time, I think between around August or September and March of the following year, so in roughly 6 months, we got up to about 300 or 400 patients that we were screening that had positive sleep questionnaires and were being referred for either a formal sleep study or a consultation with sleep medicine. I think we quickly realized there's a lot more patients here than we anticipated. And seeing all the comorbidities that come with it, and then starting to gather the data and starting to see, this is a real program that could improve readmissions, it can improve morbidity, it can improve mortality, it can reduce recurrent atrial fibrillation, it can reduce ventricular arrhythmias. And as we started to talk more about it, it was sort of like a snowball effect. The electrophysiologists were getting interested in it, the interventionalists were getting more interested in it, and the attendings were starting to talk about it on rounds and interacting with Frank. And I think the more we talked about it, the more interest there was. And that was really the turning point. As the COVID pandemic has sort of slowed down a little bit and things have transitioned back, the numbers are a little bit lower. We're trying to sort of regroup our program, like Frank alluded to. It's just me and Frank at this point, but trying to partner more with sleep medicine again and sort of get the program up and running. But I think that first 3 or 4 months where all of a sudden the numbers just took off and everybody was talking about it. I actually gave a grand rounds in our division, and a lot of people became more interested in it. I think from our world of heart failure, people look at the SERVE-HF trial and they say, this was a negative study. There's no need to focus on this. It increases mortality if we're trying to treat these people. And there's probably a subset of patients that's true for. And so I think trying to talk more about it and focus on getting the right treatments, the right interventions to try to help these people who do have a really high risk of mortality because of advanced heart failure, and trying to sort of change the opinion or change the focus that this doesn't just increase mortality. If we get people started on therapy, we may be able to improve outcomes. And the Advent HF trial, was more of a neutral trial that just got released a few months ago. And so I think there may be patients that we can help and not just sort of say, let's not focus on this. And if it's not just from heart failure, it's for arrhythmia burden, it's for coronary disease, it's for hypertension. There's a lot of comorbidities that underlie their heart failure, and we could probably address those too.
Are you a sleep tech looking for new opportunities? Well, Medbridge Healthcare is one of the largest employers of sleep technologists, and they are growing. If you are a sleep technologist interested in a new position, potential paid relocation, or looking for a career advancement, consider a career with Medbridge Healthcare. Now back to the show.
Dr. Jackson, with the pilot program or the abstract that you did with your for the pilot program, have you thought about maybe replicating some of that? Maybe trying to redo some of it, because I know the CPAP adherence was low, but it was also part of that was because there just wasn't available CPAP devices to put on patients at that time. So it just couldn't have been worse timing, COVID, and then a recall of CPAP devices.
Yeah, we were working on a grant support about a year or so ago. We were working towards trying to get grant support for the inpatient devices, some staff support for an inpatient navigator like Frank, because it costs a lot to have somebody with their boots on the ground in the inpatient setting, rather than working in the sleep lab and working with the sleep medicine division to be sort of working over in the cardiology section. So we were working on grant support. Unfortunately, that didn't come to fruition. But I think if we can either get some grant support, or I think if the landscape changes where reimbursement can change and we can have reimbursement and coding for inpatient sleep specialists or inpatient sleep navigators, who can, when there's, seeing patients, doing consultations, doing formal questionnaires, getting them set up for sleep studies. If that can eventually come to fruition, that there's, billing and coding involved, then that helps support that role, support the testing in the inpatient setting, and really, get things up and going. But doing it in a sense, for a lack of a better term, sort of charity work, the hospital didn't want to continue doing that, and they, Frank went back to, some of it was COVID and staffing issues, but went back to working nights for a while, is back on days, but really working with the sleep lab, and less so, on the inpatient ward. So I would love to replicate things, now that we're out of the pandemic, there's better supply of DME equipment, from diagnosis to time of getting on therapy not being so delayed. But obviously, there's some troubleshooting we need to do on the inpatient side at this point.
It seems like with a lot of these programs, it's one of those things where, like, you got it going, you've got to continually sell to medical staff, but it's almost like you need to continually sell to administration, because you've got to demonstrate the savings that the program creates, and it's an ongoing process of, quarter to quarter, year to year budgets of how are you creating that savings. And I think your story outlines that really clearly. Is it's a dual effort of education, both to hospital administration and physicians. So, kind of going forward, you're looking for new ways to restart that. What do you think, kind of, as you look back, what was your greatest surprise, Dr. Jackson? Because, I mean, some of this stuff was intuitive, but for you, what was sort of your biggest surprise, your biggest takeaway from the whole journey?
I was surprised, I would say, by the incidence of it. Frank started to customize a computer program by risk factors and comorbidities, and I was just shocked at the numbers of patients who were on our services that were at such high risk. We're talking about 50 patients a day on our 3 different services, that might have that would be at very high risk of sleep disordered breathing, and that was sort of stunning to me. It's not something we talk about a lot during cardiology training programs or advanced heart failure fellowship programs, and again, we're focused on the cardiology issues, but to have 40 or 50 patients, out of probably 70 or so that we have on our services every day, I was struck by the pure number of patients and really the impact that we can have. And there is, as you said, there is actually some other physicians at other programs have published some data on reduction in, cost savings. If you look at heart failure patients over 6 months, there's a significant reduction in resource utilization. There's a reduction in cost expenditures. And so there is some of that data out there, specifically with heart failure patients with central sleep apnea, that there really is a cost savings and a benefit for the hospital.
Well, we are quickly coming to the very end of our time together. I want to cover one more thing, and Frank, I can give you about 2 minutes to talk about a pretty great subject. You and I have talked about this. Every inpatient program I've ever sort of advocated for or educated on started with a stop bang, and you did have this idea to use software to be able to identify patients without asking them a single question, which I think is pretty amazing. So do you mind sharing with our audience a little bit about your dashboard, if you would?
Yeah, it started out just my brain said, how am I going to see 50 patients a day and not look like a fool and be wrong? So I needed to be 80 to 90% right. So I thought about it a little bit, and they had hired a company to come in and try to find heart failure patients. And I took that failed dashboard and fed it an AI algorithm based on a few things. I don't really want to get into the details of that, but based on a few type of things that I will just say looking at. And then it started spitting out numbers. I would go look at the patient, and voila, I ended up being, that's how the onslaught tidal wave happened. Um,
So I would say that
and
it's really a screening through medical comorbids, primarily, right?
so Tableau is linked through a basic Excel spreadsheet. You have to program, it's basically like pivot tables. So basically it's using pivot tables behind the scenes, and it's pulling that information, extracting on based on the comorbidity and what I tell it to look for. Which can be used through multiple different disease processes, but I just, I was working with Dr. Jackson and heart failure, so I had to do that. And it was pretty astounding, uh, how it came out. Like I was actually amazed myself. And part of that problem was I was tired of hearing the heart failure doctors say ASV kills people, and we can't do ASV. And I'm my brain on that whole retrospect is, what killed them first, the 4 hours they were on or the 4 hours they were off. So, and then I kind of proved that by treating the patient with low EFs in the hospital, and they got better. They got out of the hospital quicker. The medications took better. But the dashboard itself, uh, it's all right here, buddy.
All right.
It's
Well, you
just,
know what? It's you
I
have
don't want
some
to give a
sleep.
whole lot away about it because
That's all right. No, we won't have you when you're ready to start selling it to the world, then we'll have you back on again, Frank, to help
well,
monetize that effort. How's that?
I actually have a meeting with our chief innovation officer next week about this AI data mining process.
That's awesome.
And I really think that there's a doctor in Florida, Ed, you had him on with RPM, and he
Yep.
does remote patient monitoring. Now he is on the end of the spectrum I'm starting. So if we could get both of those to where they have reimbursement, and that is creating, like, we have sleep navigators, but what I was actually doing was almost acting like a hospitalist. So you would have to be respiratory and sleep because you have to be able to be an RCP to do orders, and the attendings they're not going to feel safe. If I was just had the credentialing of a sleep tech, I think that they would not see it as, I think they would see it as legitimate, but not order legitimate, not diagnosis, not helping treatment legitimate. And I think between the Tableau and that, we could definitely reduce readmissions. Hospital, I mean, they were, our hospital in particular wrote, I think, 30, 60, 90-day bundle check that would pay us all more than once.
Well, that's awesome. Hey guys, we thank you so much for joining us today. I apologize for having to get to the end of the show here, but we have to wrap. We appreciate you guys joining us and sharing about your program. This has been such great dialogue. I think that once you get things rebooted, maybe we can reconvene and continue the conversation. But we absolutely appreciate you guys joining us today.
Thank you
Excellent.
a lot.
Yeah.
I
Thank
appreciate
you,
you both.
Emerson. Yeah.
Before we go, we would like to thank our sponsor, Medbridge Healthcare. Medbridge Healthcare is developing innovative inpatient, post-discharge, and population health programs to screen comorbid conditions, diagnose and treat sleep disorders. Learn more about their innovative solutions and career opportunities at medbridgehealthcare.com. Once again, you can learn more about their innovative solutions and career opportunities at medbridgehealthcare.com.
Post cows, Emerson, what'd you think?
Wow. As we talked about in the pre-cals, it was, getting to talk to a cardiologist about these kinds of programs is fantastic. I mean, just writing the numbers down as he was talking, I mean, 80% of the patients, of those 1,000 patients, had sleep disordered breathing. I mean, that's something we kind of know, but to have a cardiologist say that and then talk about the outcomes that they achieved by, with AFib and heart failure and all of those things, I think it was just fantastic. I mean, it's disappointing that the program, it isn't where it was pre-COVID, but my goodness, the learnings they had is just something that we can all glean from.
100%. And it's interesting to me too that most hospitals and healthcare systems sort of stay away from the conversation because they know that if they start to ask the questions, it will overwhelm the sleep program, and there's just not the resources to be able to facilitate the number of patients that are undiagnosed, untreated, and inside the four walls of a hospital. But we're talking about reduced cost of care, reduced length of stay for their patients, and lower mortality. I mean, holy smokes, that's significant.
Oh, it really is. And it's interesting. He spoke to something that we all have to deal with, and it's silos. The silos they had to break down. But we mentioned this during the talk. But if someone's getting a program going or has a program, they absolutely must continually sell up. We see that with Massey's program at Wellstar. It's not just about having the great navigator team that we've had on here. He has to sell that up to administration on a regular basis. And I think that's such a critical part of what these inpatient programs have to do to succeed is they have to have a plan on how to tell their story to not just to both administration and the medical staff on a regular basis. It's an ongoing process.
And process, and I would say battle.
Yes, that's probably a better way of saying it.
Well, and
Without a
it's a
doubt.
shame. It is a shame, because to me, it just sort of screams that, my goodness, for sleep programs, just let's not take away resources. Let's add resources so that we,
Yeah.
not only generate more income for the sleep, for the hospital through sleep testing, but that we also track data, for these patients. One of the things that, especially when I have given my, inpatient screening conversation and talk is around, trying to make sure that you produce data so that there are outcomes that you can report, related to the success of the program. Because, the first thing that they're going to want to know from an administrative standpoint is how much it costs. And then the second thing is you're able to go in and fight the battle of not only have we generated more revenue, but we've also, now we've reduced the cost of care for these patients, which is significant. And then, to me, from a healthcare perspective, that's where healthcare systems can begin to have conversations with payers, and
Yeah.
really sort of scream the importance of making sure that these patients are diagnosed and that they're treated, but then also that everyone is focused on keeping that patient on path therapy.
Well, I think that to your point, it's part of what we battle across all of medicine is that sleep is more than just fixing someone snoring and sleep apnea. And until we can get the rest of medicine to see that, and even administration of these hospitals, we're still going to fight these battles. And it just tells us we've got a long way to go before we're recognized as a part of the multimodality part of care that we need to be. But this is a great, massive step. And I'm so glad we had him on our podcast today.
I agree, and I'll just add one thing to that is, I feel like also that for this patient population that there is a significant reason that there needs to be sort of, that we can't lose with these patients, and what I mean by that is that if they're non-adherent to therapy, then the next step is you get an oral appliance, and if they can't wear an oral appliance, then the next step is um, potentially the Inspire surgery,
Right.
or even the Remedy surgery if they have central sleep apnea. So
Yeah.
to me, this is one of those situations for this patient population in particular that we can't give up on those patients from a treatment standpoint.
Absolutely.
All right, Emerson, we made it.
Yes.
We recorded our first podcast without Jerry.
It's
Jerry, we
amazing.
miss you.
I didn't think we could do it. We're not as pretty without
Nope.
him, but we did definitely made it happen.
Great job. I appreciate you, Emerson. Appreciate
Thank
Dr.
you.
Jackson and Frank joining us today as well.
It's good stuff.
All right. Till the next time, like, share, subscribe, and we appreciate our audience. And can't thank you so much for all the listens, the shares, the comments, and downloads. Thank you so much, and we'll see you next time.